All right.
শুভ সন্ধ্যা বন্ধুরা, আপনারা সবাই কেমন আছেন? আজকে ফিজিও নিউজ 24 এর একটি বিষয় বরাবরের মতোই আমরা আপনাদের জন্য একটা বিশেষ চমৎকার একটা অনুষ্ঠানের আয়োজন করেছি এবং সবচেয়ে শুনলে আশ্চর্য হবেন যে আমাদের সাথে আজকে আছেন আমাদের সবচেয়ে কাছের এবং সারা পৃথিবীতে পরিচিত ডক্টর দীপক কুমার স্যার। এবং স্যারের আসা উপলক্ষে আসলে সারা পৃথিবীর মানুষ আজকে আমরা এক পৃথিবী সমস্ত পৃথিবীর 40টারও বেশি দেশ আজকে আমাদের সাথে আছে এবং আজকে আমাদের এই ক্লাসে 1100-এর উপরে পার্টিসিপেট করেছেন। তো আসলে সময় ক্ষেপণ করবো না, কারণ স্যারের কথা শোনার জন্য আমরা সরাসরি আমি ইংরেজিতে চলে যাচ্ছি এবং স্যারকে ওয়েলকাম। Hello everybody and good afternoon. And today is our very special day, and I am very glad and our team are very proud that is sir has received our invitation. And he's a very busy man and he's an international figure, not only in India but all over the world. And that's why this time we have got more than 40 countries participating along with us. And it's not only 500, 600, it's already processed 1,000, more than it should be 1,100. So I think it's a great pleasure for us, and thank you, sir, for your valuable time. And Deepak Kumar Capri sir is very commonplace, very commonplace. And he's my mentors, and I always owe him, and he's also my modern manual therapy. He's my guide. And it's my what can you say? Anything with a few words is it can't possible to introduce him or give some discussion about. I think it's very important for us to learn something from him because he's like a seed. So today we will just get skip of what from him. So, thank you, sir. Thank you for giving us a time, and I think it's time for what you. Thank you, sir.
Thank you, Dr. Shantanu. Thank you very much for inviting me, and thank you, Dr. Shamim, for inviting me for this lovely webinar. And thanks to Physio News 24 for giving this opportunity to communicate with the participants from 40 countries. That shows you people are really doing a very good job. People from 40 countries, even the national channel, you don't get people from 40 countries, and more than 1,100 people you told me. That's a honor to me. Thank you very much, all the participants, for joining me today for this webinar. And I'll make sure that the time you are investing with me and News 24, it's worthy your time, and you get the value for your time. So hi, very good evening. In this webinar, I'm going to cover a very few facts about the sacroiliac joint, because they are important to understand. And before you doing the segmental examination and treatment of sacroiliac joint, in this webinar, I'm going to cover what is sacroiliac joint and can it cause pain. So I'm going to start my presentation, and wait a while. Okay, can you see my presentation now? Is it visible to everyone? Dr. Shantanu, can you see my presentation? Okay. So it's coming, right? Okay, very nice. Okay. So in this chapter, I'm going to cover what is sacroiliac joint and can it cause pain. Why I'm saying this? Because the literature says SI joint is not very common, and majority of time people are getting pain from lumbar spine. That is why we need to discuss, can it cause pain? And then in upcoming webinars, if we get opportunity with News 24 or in our website, which we will discuss and demonstrate how to do segmental examination of sacroiliac joint. The information in this chapter is going to be from manual therapy point of view and how to make diagnosis of mechanical pain, especially coming from sacroiliac joint. Here it is important to note, I won't be covering the pathological condition related to sacroiliac joint. And we will discuss how to diagnose mechanical pain that is coming from the SI joint. And in upcoming webinars or on our website, it's already available and you can sign up for free and you can see all those things. We will discuss and demonstrate how to treat these mechanical pain coming from sacroiliac joint using different manual therapy techniques. So what do you think? What is the lifetime prevalence of low back pain? Yes, it is 80%. 80% is the lifetime prevalence for low back pain, means 80% people do have back pain sometime in their lifetime. And it is very much second to common cold and cough. It is the 5th commonest cause for hospital admission. And it costs $86 billion per year to the society. So which structure could be the potential pain generator causing low back pain? If it is coming from spine, it could be facet joint, it could be disc, could be ligament, muscle or bone. And many clinicians examine their patient having low back pain, keeping only these structures as potential pain generator in their mind. So if a patient comes to us with low back pain, we look for the facet, disc, bone, and muscles. Rarely we go for hip joint and for sacroiliac joint examination. Reason being, patient already walk in with their x-rays of spine or CT scan or MRI films and reports in their hand, due to which there are high chances of clinician getting biased towards the finding giving in the report and imaging films. And in this process of evaluation, SI joint get ignored, obviously. Also, it is important to note there are usually no comment about SI joint in those reports. Report comments usually on disc, facet joint space, ligaments, nerves, bones, or muscle, etc. And rarely comment on SI joint as the prime focus is on lumbar spine. Another reason for this scenario could be that imaging studies are often inconclusive for SI joint. I repeat, they are inconclusive for SI joint. So if you want to diagnose sacroiliac joint and you send your patient for CT scan, chances are it's going to be inconclusive. In one of the study where CT scan was performed, it was found that CT scan was normal in 42% subjects suffering from sacroiliitis. Means they were symptomatic and have sacroiliitis clinically, but CT scan was absolutely normal. And in case you wish to see the SI joint in X-ray, please don't advise patient to go for plain AP view. In that view, you will get the overshadow and you may not be able to see the SI joint properly. So it is recommended that one should go for left oblique and right oblique view of the sacroiliac joint. Now you must be wondering, why both sides? Why not only the affected side? Now remember, if patient complains of pain only on one side, still you need to get it on both sides so that you can compare the affected one with the healthy side, obviously. And in X-ray, you are going to check for sclerosis of the joint line, look for the effusion or fusion of the joint. So all those things you can see in an X-ray with left oblique view and the right oblique view. Though in few cases, it might still look normal and patient might still be having sacroiliitis. And then it is a good idea to go for MRI scan for those cases to get better outcome about the condition of the sacroiliac joint. Now, do you know, as per research, 25% people, almost 1/4, 25% people having low back pain, having pain because of sacroiliac joint involved. Means if you receive 100 patients with back pain, out of those, almost 25 patients will be having SI joint problem. And this is what the literature says. But in my experience, this percentage is much higher. Maybe because these studies are done in a different geographical location, in different socio-cultural population, having different lifestyle and style of working. Also, it is much more common in elderly, obviously, because of the degenerative changes. Because of the aging, they get the degenerative changes not only in the lumbar spine, but also in the sacroiliac joint. So now, when we know 1/4 of low back pain are because of SI joint involvement, how can we afford to miss SI joint evaluation in patient having low back pain? Before I discuss how to assess SI joint, let's discuss some important anatomical aspect of this joint. As we all know, it is the largest axial joint in the body. Okay? So it is the largest axial joint in the body, and it is a true synovial and diarthroidal joint. It has a hyaline cartilage and synovial membrane like any other joint. And it is also subject to same pathology like any other joint. You know, the average surface area is 17.5 square centimeter. And it is a weight-bearing joint. It's a triplanar joint. It works as a shock absorber. Because when the force comes from spine, it gets diverted to both ilia, to left as well as to the right. Okay? So it gets diverted, both ilia on left and right, and it absorbs shock. And then transmit load from upper body to the lower one. Unless the person is suffering from ankylosing spondylitis, SI joint usually does not get fused. Whereas in case of ankylosing spondylitis, this is the first joint to get fused. Unlike other joint, it has a complex anatomy. The shape of the joint is like a boomerang shape. People also call it L shape. And on top of it, it does not have smooth surface. It has irregular surfaces. And because it is irregular, it gets locked very nicely with ilium. Because ilium also have irregular surface. It's small mountains, you know. You have small mountain and then mountain to mountain, it gets locked easily. Additionally, there are ligaments, strong ligaments, capsules, muscles, which hold the joint quite strongly. So it's a very rigid, very stiff joint. It does not move much. And to move it a bit, you need to apply good force in order to mobilize it. Also note, SI joint is highly innervated joint, like fat pad, you know, in our knee joint. The fat pad is highly innervated one. Small irritation in patellofemoral joint, that gives pain in the fat pad. Same way, SI joint also slightly get disturbed, it will give you very severe pain. So it can produce very severe pain when it is inflamed or malpositioned. So as I said earlier, SI joint pain often get mixed with the back pain. Okay, often get mixed with back pain, also because SI joint can even mimic discogenic low back pain or radicular pain, potentially leading to misdiagnosis. At some time it can give the radiating pain also. And soon we will discuss how to differentiate whether it is coming from the sacroiliac joint or from the lumbar spine. This you can make out while taking history as well as while doing the assessment. And remember, there could also be a situation where it can overlap with referral pain. You get the referral pain in case of discogenic problem, but even in sacroiliac joint, you may get referral pain. And then it is a very confusing situation. The clinician thinks whether it's coming from the disc or from the sacroiliac joint. But don't worry, we'll discuss how to differentiate whether it is a disc or the sacroiliac joint. So there could also be a situation where it can overlap with the referring pain, which might be coming from the disc prolapse. So what could be the potential cause behind sacroiliac joint pain? Patient may give you history of fall on buttock while, so this is the appropriate slide now. So patient may give you history of fall on buttock while playing football or cricket. Okay, fall on buttock while playing football or cricket or running, or fall can cause him to land on his ischial tuberosity. And direct impact on ischial tuberosity can cause the ilium to get pushed up. Another reason could be motor vehicle accident. Now you must be wondering, how come a motor vehicle accident can cause sacroiliitis? Yes, because I'm sure you must have studied the dashboard injury or the bumper car fracture. But here I'm not talking about dashboard injury or bumper car fracture. Let me help you in this understanding the mechanism of injury in case of SI joint involvement. Now I want you to imagine a person driving a car and has to apply a sudden brake, okay, with the right leg, right? So now his right foot will be in closed chain circuit on brake pedal, right? Brake pedal, and therefore right leg, imagine this is the right leg, okay? And therefore the right leg is locked up till the hip joint and therefore the ilium bone. But remaining portion of the body is not locked with the car. And if this car stops suddenly with a jerk, the whole body will move forward due to momentum. Okay, the whole body will move due to momentum in forward direction more than the car, while the right leg, which is locked on brake pedal, will stop along with car. So there will be a stress coming at the very first joint that is locked between leg and the remaining part of the body, that is the sacroiliac joint of the right leg, isn't it? I'm sure you are able to imagine it now. And if this movement is strong enough to cause strain or torsion, the SI joint will be inflamed or malpositioned. So I'm sure now you are able to imagine this mechanism of getting positional fault at sacroiliac joint. In female, the cause of sacroiliitis could be your childbirth. We know in third trimester, relaxin hormone get released. And during baby birth, ligaments have to give way for the normal delivery of the child. And thus, SI joint often get strained, stressed, resulting in torsional injuries to SI joint. Another cause for SI joint pain could be heavy weight lifting and or twisting, which can also produce trauma to the SI joint. Or the patient might give history of some obvious trauma like history of fall on buttock. Also be careful while taking history, make sure you rule out the yellow flags as well as the red flags before you take the patient for manual therapy. Obviously, you will be asking all the precautionary questions, and this reminds me of one of my young patients. This is a very interesting case. You must listen to this very carefully. He was a young patient I treated a couple of years back, and this young boy came for SI joint treatment but did not respond at all to therapy. We reassessed the patient in detail and noticed there was no history of, there was absolutely no red flag or yellow flags. Like no fever, no loss of weight, no loss of appetite, nothing at all. But still, he was not responding to treatment. So we sent him for MRI of Sacralic Joint. And to our surprise, we found pus formation in sacrum. Though related blood tests were still within normal limits. And this is a very extremely rare case, and we also have seen this in his case only. But still, I would say sometime when patient is not responding with your treatment, think of something serious. Re-examine the patient, take second opinion, and get detailed testing done. In usual cases, best thing is to find out red flags or yellow flag is that if the patient is not getting, if your pain is not getting provoked or not getting relieved because of movement, means the pain must get provoked or get relieved in certain movement. But if it is not getting provoked or if it is not getting relieved because of any movement, think of some pathology. This is important in case of mechanical pain especially. The mechanical pain will always increase or decrease with movement of that affected joint or by putting stress or strain on it. If it is moved in appropriate direction, okay? Chances are that sacroiliac joint may get involved even with any trauma or jerk. So what could be those atraumatic causes? So let's discuss now the atraumatic causes. The answer is adjacent segmental disorder, lumbar hypomobility, PO. Obviously, if the lumbar spine is not fully mobile, so the stress will come at the sacroiliac joint. Because each lumbar vertebra move 5 to 10 degrees only. But if any 2 or 3 vertebrae get fused, then entire stress of movement will come on the sacroiliac joint. Because this is the very next joint which is mobile, though it very, very limited mobility. And I'm sure you are aware you get more degenerative changes at cervicothoracic and lumbosacral junction. Cervicothoracic and lumbosacral junction. Because after great mobility in higher segment, there is sudden hypomobility in the lower segment. So that forms the hinge and hence causing early degeneration. Same thing is applicable to sacroiliac joint also. So if the lumbar spine is hypomobile or fused, that could be because of surgery, or after plating or nailing, and it becomes like a block. It moves as a single segment. Instead of moving as multiple segment, it moves like a single segment. And obviously, when it is behaving like a block and it moves like when it is like a block movement, all the required movement has to happen somewhere else. And then it is the sacroiliac joint which get torsion. Because there is no movement happening at the lumbar spine. And all the stress will come at the sacroiliac, because that is the first mobile joint now. After that, the ilium and the hip joint comes. Okay? So it is the sacroiliac joint which get torsion. So make sure you assess your patient after surgery for sacroiliac joint dysfunction, especially after surgery, especially in case they are coming after fixation for spondylolisthesis or for some other cause. Another non-traumatic cause could be your scoliosis. Because of the scoliosis, there will be uneven force on SI joint on one side, giving strain to it. Then postpartum, that could be another cause for involvement of sacroiliac joint, which we have just discussed in case of normal delivery. And another cause could be the inflammatory arthropathies or infection. In case of infection or inflammatory arthropathies, even resting position, including lying in bed, would be painful. And movement may or may not make any difference. So check the history properly. And as per research, 44%, it's a big percentage, okay? 44% of people will have sacroiliitis or sacroiliac joint pain because of traumatic injuries, while 21% people will have it because of the cumulative injuries, like repeated stress and strain while doing day-to-day activities or bad posture, resulting in repeated micro trauma. And obviously, you physios do understand all those things. These cumulative injuries could also be because of wrong ergonomics, or too much of walking, jogging, or too much of stair climbing, again resulting in repeated micro traumas. And this is why SI joint may pain. Then 19% people will have SI joint pain after lumbar surgery, while 16 people, your 16% people will have sacroiliac joint pain, which is idiopathic in nature, means no cause behind SI joint pain. Okay, let's proceed further. The prevalence of SI joint pain. As I discussed earlier also, out of all low back pain cases, around 22% people, that is almost the 1/4, okay? Around 22% people have SI joint pain, or as I told you, in my personal experience, it is much higher. Also, you will be surprised to know 43% people, 43%, that's a big percentage. Okay, 43% people after lumbar fusion or after lumbar surgery, after lumbar fixation, they do get sacroiliitis, sacroiliac joint pain. And when they come for physiotherapy, one wonder what treatment to be done, because the spine is already fixed. Now remember, probably it is not the operated site which is causing pain now. Probably it is the sacroiliac joint which you need to address. Okay, so I hope this is a good information for practicing physio as well as for the students watching this webinar. So this is another study which I must explain here, which says that those who got operated because of any XYZ reason, be it microdiscectomy or lumbar spine fixation or laminectomy or fusion, at later stage, 75% people showed SI joint degeneration as compared to those who did not got operated. So 75% people got SI joint strain, those who got operated, while only 38.20 got SI joint at later stage of life, even if they were not operated. Okay, so just 1 second, let me fix my laptop. So this study says who got operated because of any XYZ reason, be it microdiscectomy or any surgery, at later stage 75% people get SI joint degeneration as compared to those who did not get operated, and among those who did not get operated, only 38.2 people got degenerative changes, but those who got operated, 75% people got degenerative changes in SI joint. That means after surgery, if pain is coming, it could be because of sacroiliac joint pain. You know, after surgery, many patients think the disc is out now, so there's no problem in the spine, or now it is already fused, and they don't need to do any mobility or any strengthening exercise. Many times they just overprotect their spine and adjust their spine and the nearby joint, adjacent joints, because of which these joints also starts getting affected. So proper post-operative rehabilitation to the spine and to the nearby joint is very important. That includes the sacroiliac joint and the joints above the lumbar spine and below the lumbar spine and the hip joint also. Now, how do you check whether it is sacroiliitis? A beautiful and very easy way to check or diagnose sacroiliac joint, your sacroiliitis is 14th finger test. So how to perform this 14th finger test? You know, when a patient comes to you and you ask, where is the pain? Then you ask him to put one finger exactly on the site of pain. And patient will put it exactly on the PSIS of the affected side or within the radius of 1 to 2 centimeter of PSIS, posterior superior iliac spine. And if we ask him to remove the finger and put it again he will put the finger in the same place, okay? This is one of the confirmatory tests for sacroiliitis, and it is called 14th finger test. In addition to this, obviously, you have to do the examination. You shall take the detailed medical history of the patient, and then you do the physical examination. You ask about the presentation of the pain. Take the history of trauma or jerk. Ask for diurnal variation, like what increases, which time do you get more pain? Morning or evening? Okay? You ask if it is not immediately after getting up in the morning, you get pain. Okay? It's going to be something else. But moment patient put the foot on the leg and he get pain exactly at the sacroiliac area only, probably it is the sacroiliitis. Because for the whole night, he has not moved. And because of the inflammation, the transudate and the exudate got accumulated in that area. But when he move around for 5-10 minutes, the pain get disappear. But in case of disc prolapse, this pain will not get disappear. It may stay maybe up to 2 hours. Okay, so you ask for the diurnal variations, whether he's getting more pain or the less pain. Disc pain will be less in the evening, while the sacroiliac joint pain will be more in the evening because you are constantly loading the joint. It's a kind of facet joint, okay? It's a facet joint. It's a wrong terminology. I know I'm calling it a facet joint, but you can consider it like a facet. It's a facet between L5 and it's a facet between the sacrum and the ilium, basically. So the kind of symptoms you get or the way you diagnose sacroiliac joint, facet joint orthopathy, similarly you can also diagnose the sacroiliac joint also. The same kind of history patient will give. The kind of history patient will give for facet joint orthopathy. But the location will be different. Aggravating factor and the relieving factor. Check for the aggravating factor and the relieving factor. Do the physical examination, not only for the lumbar spine, but also for the sacroiliac joint, as well as for the hip joint. And then the 14-finger test, which I told you just now. And then you also need to do the segmental examination of the sacroiliac joint, checking the active as well as passive range of motion, along with provocative test. In the upcoming chapter or on our website, that is www.capriforphysio.org, You can sign up for free, and there I will be showing you those provocative tests from manual therapy point of view. Try to understand and remember the physics, the force, the vector behind these forces, and what structure or portion of the joint getting stressed, getting compression. Provocative test means, you have to provoke the pain, not a pain. The pain is the same pain what patient complains of, the relevant pain I'm talking about. So while taking medical history, what will be the chief complaint of the patient? Patient will complain pain below L5, not above L5. Okay? Not above L5. So patient will complain pain within 1 to 2 centimeter area of the affected SI joint or posterior superior iliac spine. Then pain may also go down the pelvic or the buttock area. Okay. Then sometime, the sacroiliac joint pain can also travel in the front area, the groin area. And we all know when we talk about pain, we know that pain can travel front to back and back to front, but not from left to right or right to left. That means if it is the left side which is affected, patient will get pain on left side essentially. Okay. Sometimes patient may also complain of disturbed sleep pattern, because turning in bed is painful. Why? Because when you turn, the sacroiliac joint gets strained. Obviously, there's more torsion over the sacroiliac joint. And then the disturbed sitting pattern may also be noted while doing postural and physical examination, as patient doesn't want to do loading on the affected joint, and probably he won't sit straight. He will try to offload the affected joint. So when patient comes to you in the clinic, check his gait pattern, and you can make out that he's not putting much load on the affected side. As well as while standing also, he won't be putting much load on the affected side. And if you notice, you may notice sometime, not always, but sometime, you may notice that patient is keeping a very heavy wallet in his back pocket. So that will also alter the biomechanics of the sacroiliac joint. So check for that also. Okay, back to the same one. So same thing is true while sitting, as well as patient don't want to put load on the affected side, and you can check for the unilateral leg instability, and pain can also go to the lower extremity. As I told you earlier also, even in sacroiliac joint, pain do get radiated down the leg. So now these are the few important points to keep in mind when you diagnose the sacroiliac joint pain. Sacroiliac joint pain will never be in the midline. Okay, sacroiliac joint will never be in midline. And if it is in the midline, it is coming from elsewhere. It's going to be either left or right. As I told you, pain cannot travel from left to right or right to left. It can travel front to back and back to front, but not from left to right or right to left. So it's going to be either left or going to be right. And if it is bilateral, then it's going to be left as well as right, but not in the midline. And it's always going to be below L5. Okay, so as we have already discussed, it's always going to be below L5 within 2 centimeter area of the affected PSIS. Occasionally, it may go to groin area or the posterior lateral thigh or to the calf. Most commonly, patient point to the PSIS. And we have already discussed it as a 14 finger test earlier, just now. Okay. And these are the aggravating as well as the relieving factor. rolling onto the, what are the aggravating factors? Rolling onto the affected side in the sideline from supine gives pain. And that is why the patient complains of disturbed sleep. Sit to stand may also give pain because of extra loading at SI joint while standing, especially from a low height chair. Prolonged walking will also give pain, especially during stance phase. Means when you're putting load on the affected side, that will give you more pain. Getting in and out of the bed, getting in and out of the car may also give pain, as these activities also put a strain on SI joint. And the SI joint is a very nasty joint. Even in sitting, it gets loaded. Unilateral weight bearing will also give pain, like putting pant or socks or climbing stairs. Because during climbing stairs, when you put the affected leg on the stair, you put extra load on SI joint. Now let's discuss what will be the relieving factor. Weight bearing, obviously the weight bearing on the unaffected side, lying on unaffected side, because there is no compression over the affected sacroiliac joint. Manual compression over the SI joint with belt. You use the belt, especially the male, they use belt over the pant, and when they compress it, it stabilizes the sacroiliac joint, and that may also help in relieving pain. Because if there is a hypermobility of sacroiliac joint, that will make it stabilize and this will only help in case of unstable joint, and will give pain relief in these cases. So when you do the physical examination, first of all, you will check the posture, and next will be the palpation. Check for the tenderness over the affected PSIS and over the sacral sulcus. Just medial to PSIS, you get a small dent which is quite soft also. That is the sacral sulcus. Check for the tenderness over the dorsal ligament insertion. Check for the tenderness at the pubic symphysis. And I understand that, in country like India or Bangladesh or in Asian countries, might be difficult to palpate the pubic symphysis. So it is okay. Sometimes you may ask your patient to palpate it by themselves, and they can tell you whether it is painful or not, because malpositioning of sacroiliac joint will also affect the pubic symphysis. Then we check for the range of motion. Like in peripheral joint, take the example of knee joint, in shoulder joint, we check the active range of motion as well as the passive range of motion. Then why not in case of a spine, and then why not in case of sacroiliac joint? We shall check the active range of motion as well as the passive range of motion. Okay, and in upcoming chapter during, just 1 second. Why my mouse is not working? So we will discuss how to check these active range of motion. 1 minute. Let me fix it. Okay. So in upcoming chapter during practical demonstration, which is already available on our website, capriforphysio.org, next Sunday it will be available for free to all the registered participants next Sunday. And you can sign up for free. There I'm going to show you how to check these active range of motion as well as passive range of motion in sacroiliac joint and in spine. And then we will also be doing the provocative test. We'll be doing the multiple provocative tests, and as per literature, out of 5, 3 tests should be positive. Okay, remember, any neuromusculoskeletal pain, if can be provoked, will get provoked either by maximum compression or by maximum stretch. Any neuromusculoskeletal pain. Here I'm not talking about visceral pain, okay? I am talking only about neuromusculoskeletal pain. If can be provoked, will get provoked either by maximum compression or by maximum stretch. And you will notice all orthopedic tests are designed in such a way that either you are trying to compress or trying to stretch the affected structure to check if the pain is getting provoked or not. Okay, same way it is true for SI joint also. So whenever you do these tests, try to see, analyze the physics involved in that. Don't try to learn the test, try to learn the physics behind it. Try to learn the concept behind it. And you know, when you get experience, you can design your own test, you can modify your own test. You need to understand what structure is getting stretched. What are the vectors, angles, force, and all those things. Then you have to do the gait assessment, single leg stance, the functional testing, ADL score, the stair climbing, sit to stand, and active SLR. I'm not saying passive SLR, it is active SLR. Then the gold standard test. Though the physio don't do it, it is the job of orthopedician, but you must know. The gold standard test, you know, for SI joint is injection. And if after doing all those tests also, you're not sure whether it is sacroiliac joint or not, then one can inject lidocaine. Okay, injection 1.5 ml lidocaine in the sacroiliac joint, affected sacroiliac joint. And after 20 to 30 minutes, if patient is almost 80% better, that means it was the sacroiliac joint. So you can inject lidocaine, and not just once, but it should be repeated after few days to reconfirm before sending patient for surgery for fusion or fixation of the affected sacroiliac joint, to make sure that it is the sacroiliac joint which is giving pain. Okay, so this is the gold standard actually in medical practice to confirm the diagnosis of sacroiliac joint involvement. Obviously, physiotherapists don't do this test, but it helps to confirm the diagnosis of sacroiliac joint involvement. So how mobile the sacroiliac, now next thing is how mobile the sacroiliac joint is. Obviously, very, very less mobile, very, very stiff. It moves just 4 degrees in any plane, just 4 degrees. And in male, it is further reduced to 1 to 2 degrees, while in female, it is 2 to 4 degrees. And not just nutation or counter nutation, the sacrum can also translate in AP direction. So not only nutation and counter nutation. Sacroiliac joint, your sacrum, not sacroiliac joint, sacrum can also translate in AP direction up to 1.6 mm. Yes, 1.6 mm. And it is very difficult to appreciate until you develop those palpation skills, until you practice it well. And you may find it difficult to appreciate sometime, especially in case of obese patient. And you may find few physios claiming that it is just cannot be appreciated and there is no movement at all. And then at the same time, there are physios who can easily appreciate all the joint play, you know. And you know, the sacrum can also rotate in axial direction. Not only the nutation, counter nutation, or translation forward, backward, but also the axial rotation by 1.5 degree. And then the lateral bending, you know, it is rotating axially and then 1.5 degree lateral bending by 8 degree. So in axial rotation, it can rotate by 1.5 degree, and for the lateral bending, it can go 0.8 degree, which is again less than a degree. Could you believe this? Less than a degree, which is again very, very minimum. I'll give you a good analogy to understand these movements. It's like a earthquake. A lot of energy is required. But how much the earth moves during an earthquake? Just a bit. And so much of energy is released. Same way in SI joint, because of presence of a strong ligament around the joint and the muscle. It doesn't move so easily. It is very subtle, but can move and can be mobilized if required. Now I'm going to show you some animated videos where I have exaggerated those movements by many times so that it is easy to understand and imagine which movement we are talking about. And it is just not nutation or counter nutation. There are multiple axes because the sacrum moves in not in one axis, but it moves in 3 axes simultaneously. So it's not pure nutation or counter nutation, up slip or down slip. It moves in 3 axes simultaneously. And I'm going to show you now all the axes that you can understand, and so you can understand the assessment as well as the mobilization technique for the same. So on the screen now you can see these are the axes. We have the your coronal axis, then we have the vertical axis, and obviously in the coronal axis you get the nutation and counter nutation, and around the vertical axis you get the rotation, and then you will see the sacrum rotating around its axis, and then you have the right oblique as well as the left oblique axis as well. So you name the axis as per it is passing from the top end of the sacrum. So this I'll call as right oblique, and this I'll call as left oblique, and this is the vertical axis, and that's the coronal axis. Okay, so now I'm starting this video, and let me tell you again, we have exaggerated these movements by many times. So let's see it now. Are you able to see this? So this is the nutation and counter nutation coming around the coronal axis. We have exaggerated these movements by many times. This is what you are able to see from the superior aspect, from the bird eye view. Okay. And this is the rotation around the vertical axis. You need to understand those things because this will help you in examining your patient as well as while mobilizing the patient. Now this is around the left oblique. And you know, I always say it's like a Garba dance. During Garba dance, you're going forward, backward, then you're rotating, you're going obliquely like this or like this. So if you can imagine the Garba dance, you can imagine all the movements of the sacrum joint. I call it a dancing bone, though it is very stiff, but it's still like a dancing bone. It goes in all the directions. Okay, so and the same way, let's watch the ilium bone now. Okay, so it can go forward, backward. Now the same movement from the other angle. Same movement, okay? And then it can go up slip and down slip. So you can imagine now. And then look for this. This is for the in flare and out flare. And I'm going to show you from different angles. Again, the same in flare and out flare. See, one time this portion of the boomerang will get jammed, while the other time this portion will get jammed. So while doing the stress test, okay, so this is the anterior tilt and posterior tilt. Again, different portion of the sacroiliac joint will get involved during this anterior and posterior tilt. You can imagine those things. It's easy to imagine now. Okay, so I'm sure you are able to make out those things. And you can assess, you can examine your patient based on these biomechanics. And this is how this amazing SI joint is. And I'm sure given information will be useful for the purpose of clinical practice as well as for assessment and for diagnosis. Thank you very much. If there is any question, I can take those questions.
Thank you, sir.
It took almost 1 hour, I believe.
Yes, sir. I think
if there was more time, I would have shown the practical also, but maybe on some other time, on some other occasion, we can show the practical. At the same time, those who are registered with you, as I requested, you can give me their details and we'll register them at our website, and they can attend the practical part of this free of cost. We allow them to see it free of cost on next Sunday. So you can give those details, or they can also go themselves to our website, capri.org, and sign up for free. Now, if there is any question, you can
okay, sir. I'm looking for that, Professor. Okay. I think there is no question. On announcement for all participants, that is feedback link will be given in that live chat. So from there you can fill up the feedback link and daily you can access the certificate on your email. So on question is sir, on questions from that is there is any condition called pinch SI joint? Sir, can you hear
me? Don't go by. I always tell my students not to remember things by the name of concept or name of. Though we have to acknowledge and give credit to the one who has invented, but they should see the physics and the rationale behind it. Okay, so if there's a pinch syndrome in sacroiliac joint, that suggests something getting pinched between the sacroiliac joint, and I will obviously try to do the provocative test for those and check which provocative test is giving more pain to the patient, and then try to do the opposite of that to relieve that pinching of the structures getting involved in that. So if you try to see everything from, you are the physical therapist, and you have to see everything from physics point of view. So if something, same thing like as I said, in facet joint also, the synovial fold get impinged, and then you have to go for the flexion based exercise and open it and pull it back by contracting the multifidus muscle. Similarly, in sacroiliac joint also, you do the provocative test, and if that is giving pain to the patient, it doesn't make difference who said, what said. You have to see the physics and fix it. And if no movement is provoking pain or relieving pain, you will think of red flags. So if you see when I teach the provocative test, I don't teach them by name. I try to teach them to see which structure getting compressed, what structure getting stressed.
Yes, sir.
And this is how you will grow further. If you learn only the technique, you are a technician. But if you learn the rationale behind it, you will be the professional.
Yes, sir. So someone asked about some explanation on red flags and yellow flags.
What explanation they want? Like they have to check ask all the precautionary questions. Ask about the weight loss, ask about the loss of appetite, ask about the low-grade fever, ask about cough and cold, and check for the range of motion, check if there is any aggravating factor or relieving factor. If general conditions of the patient you need to check. And if you are able to sense, any experienced clinician will be able to pick those things very comfortably when they ask all those things. Okay? So they can easily pick those things.
Yes, sir. Sir, that is Alisha Purana asked about that. Is manipulation of SI joint helpful for relieving pain?
Yes, if it is manipulated in the right direction, it will help the patient for sure. It is no matter whether you are giving grade 1, grade 2, grade 3, grade 4, or grade 5, you are basically mobilizing the joint. When you do it in grade 5, you call it manipulation, but actually you have to push it in the right direction. And I also teach one thing to my students, if worse, reverse. Sometimes maybe, your assessment might be wrong, and you may deliver the glide in a wrong direction and may make the condition worse. Simply do the opposite glide or manipulate in the opposite direction, mobilize in opposite direction. And in my experience, out of 100 patients, only 5 patients need high velocity thrust manipulation. 95% patient will get result because of mobilization. 95. And in mobilization, which is much, much more safer than manipulation.
Yes.
Because if mobilization, even if you over-treat the patient, you're still not damaging that much. But in case of the manipulation, you are damaging, or you are doing the irreversible damage. We have seen few cases which got paraplegia, quadriplegia, fracture because of the wrong manipulation. I must say wrong manipulation. So I'm not saying manipulation is wrong. I'm saying if the person is not trained properly, they do not know how to manipulate, then it is wrong. Better to do mobilization. It is much safer to do mobilization. But yes, once you get master those things, of course, you can do anything, manipulation or mobilization. And it helps.
Sir, another question is someone asked about to distinguish the radicular pain that is arrive from a spine or SI joint. How distinguish?
Okay. In case of radicular pain, you will be doing the palpation of the nerve also. The neural tissue is a continuous structure. And if it is sensitized throughout its course. And as I said, there will be a tenderness within 2 centimeter area of the sacroiliac joint. Okay. But in case of radicular pain, patient will not be having pain in that area, patient will be having pain in other areas. And then your neurodynamic test will be positive in case of the radicular pain. Then spine movement will make difference. So for that, you have to do the segmental examination of the spine. And suppose when you are doing the segmental examination of the spine and you ask the person to move forward, suppose it is a sciatic nerve. So, and it is the L4-5 which is involved. And you look for the L4-5. And when L4 moves and patient says, yes, I got the pain now. He has not reached the L5 level or spectrum area. Still patient is complaining pain. And it is going to be the radicular pain. Then it is the radicular pain. And obviously, you will be palpating the sciatic nerve in the gluteal fold, and the part of the sciatic nerve, peroneal nerve, and the sural nerve in back of the popliteal fossa as well as in the foot. But in case of sacroiliac joint involvement, those nerves will not be mechanosensitive.
Thank you, sir.
And then provocative test also you'll be doing for sacroiliac joint. So stress test, and then the shear test, then Gensling test, so many tests are there. And then you will be checking the active range of motion and passive range of motion at sacroiliac joint. So if active range of motion and passive range of motion is also giving pain, it's sacroiliac joint. There are so many ways. It's so easy, very easy thing to differentiate whether it is sacroiliac joint pain or the radicular pain.
Sir, someone is asking about any best exercise for SI joint.
No, there is nothing best. It might be best for you and maybe the worst for someone else. There is no such best thing for SI joint. But yes, we can say the strengthening of glutes which is the quadriceps of the SI joint and the hip joint. So strengthening exercise of the gluteal muscles will help majority of the patient. It will help in case of unstable joint. It will help in holding the joint in a proper position. But this is not a guarantee. You have to examine the patient. It has to be individual one. Okay, you have to examine the patient and do the things accordingly. It cannot be the same thing for all the patients.
Yes, sir. Sir, another question we'll take, like Pooja Chaudhary. She is asking about some difference between two tests, like SLRT and LASIK test.
Sorry?
Pooja Chaudhary, she is asking about the differentiation between, that is, SLRT test and LASIK test. That is, they both are same or not?
Excuse me, I'm not getting your voice.
Okay, sir, Pooja, I am audible, sir? Hello, sir, I am audible, sir?
Hello?
I am audible, sir. Audible, sir, I am. Hello.
No, what is the question?
Question is the two tests, that is SLRT and with the LASIK test. What is the that is the both tests are same or not?
LASIK test is basically again to check the the radicular irritation. Okay, and if it is positive only when the pain is less than your SLR is your less than 45 degrees. And what is the other test if you're asking? SLRT.
Yeah, SLRT. Yes, sir.
Straight leg raise.
Yes, sir.
Okay. Okay. As I told you, don't go as per your name of those. You have to understand the biomechanics behind it. In case of SLR also, even in less than 45 degree, I can put it as a radicular pain in one patient, and another patient I can put even at 90 degree. So you have to compare with the other side. So one test is less than 45 degree, another test is above 45 degree. I don't go as per those degree wise. You have to compare with the other side. Students very easily get confused. They says if it is less than 45 degree and it is positive, this is the test. If it is above 45 degree, this is the test. No, don't go like that. This will only confuse you. You have to compare with the other side. In gymnast, even 90 degree may give pain. Okay, and I'll still call SLR positive. And in a stiff person, those who are not doing exercise, even in 20 degree, I will say SLR negative. So that does not give any outcome. Don't go as per angle. Don't go as per degree. You have to compare with the other leg and check out in the other leg also if the person is getting the pain or a pain. Check for the pain or a pain always, and then do the passive neck flexion also. So I don't go as per 45, less than 45 or above 45. I go as per comparison with the other side. Then do the passive neck flexion, as it is the continuous structure. If passive neck flexion makes the condition worse in affected side, I'll call this test as positive. But if it make no difference, I'll say negative. So it depends on the mobility of the person, how mobile the nervous system person is having. For sacroiliac joint, as I said, I'll go for active SLR, not passive SLR, because during active SLR, the biomechanics is totally different. The muscle action is different. It compresses the joint, okay, and then it gives the pain. But in passive SLR, you are basically doing for the nerves. So I'll not go again as per the degree. LASIK test is positive if it is less than 45. I don't go as per those things. Okay. It's just the different names different people have given. They all are SLR basically.
Thank you, sir. And last question we can take, sir.
Please.
Okay, sir. Thank you. Sir, someone asks about that when the mobilization will be perfect, like in acute case or chronic case?
Sorry?
For mobilization, which condition we can choose? Like for acute case will be perfect or chronic case will be perfect?
For mobilization,
is acute case is
your voice is cracking. For mobilization,
okay, sir. Acute we can use mobilization on acute case or chronic case?
Acute versus chronic in mobilization. Okay.
Yes, sir.
Which case we can do, right? This is the question?
Yes, sir.
Okay. Okay. For manual therapy, acute pain is not a contraindication. Okay, it's not a contraindication. Remember, pain is your friend, not your enemy. It tells you there is something wrong with the body. So, again, my style of teaching and training is on treating the patient is very different. I check, how I check the indications for mobilization. I tell my students, if it is not contraindicated, it is indicated. Simple. If it is not contraindicated, it is indicated. You must give it a try. Try if it is helping or not. And when you are giving a try, while doing this, make sure you are not increasing the pain. You are not provoking the pain. Your procedure must be pain-free, pain relieving. Your procedure must increase the range of motion, must decrease the pain. And no matter whether it is acute or chronic, if you are reducing the pain and increasing the range of motion, it doesn't make sense to me why I should not be doing. Think differently. Don't just follow what is written in the books. Being a clinician, many times we don't do what is written in the book. We do very different thing in the clinical practice. And that is why maybe sometime, not always, sometime, the one who is topper in the class, the gold medalist, they don't do very well in the clinical practice. And those who are average people in the class, thinking always out of the box, thinking always, challenging always the books, the statements, they do better in the clinical practice. So I don't tell my students to just follow the books blindly or follow me blindly. I say you must try it and check it. So even in case of acute pain, you are helping the patient. Pain is going, why you should not do it? Yes, maybe. In case if there is a trauma, acute trauma, okay, there is a rupture, the pain will be so severe, the pain will not allow you to touch. And any glide will not work. And if it is not pain relieving, if it is not helping the patient, means body is telling, sorry, give me some rest. That should be the limitation. Not again contraindication, but limitation. And once the soft tissue get healed, you must again try. Because we work on biomechanics, we work on positional fault theory. Whenever there is a trauma, there has to be some positional fault also. So maybe the broken area is getting healed, but positional fault won't get corrected, and patient still will have pain. In our workshop, we regularly get a physio who sprained their ankle 5 years back. And they are the physio. They must have taken proper treatment in the physiotherapy, right? They must have done all the rehabilitation. Still, it is causing pain to them. And when we mobilize their fibula, we put it back, the pain goes off. Just 5 years old pain in just single glide, it goes off. That shows the healing took place, but still the positional fault was there. So even in acute case, maybe the pain is not coming because of the trauma, maybe because of the jerk, person got the positional fault, and you put the positional fault back into its place, and the patient gets better. So I won't remember it like acute or chronic. I'll remember if it is not contraindicated, it is indicated. Give it a try. It should be pain relieving. It should be pain reducing, and patient should feel comfortable. And if it is not helping, okay, do it. And remember one more formula. If worse, reverse. If worse, reverse. You have done the posterior medial glide at sacroiliac joint, okay? And patient says, ouch, that's giving me more pain. It's okay. Just give the anterior lateral glide and it will be fixed. So easy. That means you have created a bigger positional fault by giving the posterior medial glide. And like in physiotherapy, actually, people may laugh on this statement and people may disagree, and I'm fine with that. It's okay. It doesn't make difference to me. I don't give damn to those things, even if they laugh. So in physiotherapy, we actually don't treat patients. In the name of assessment, in the name of treatment, we repeat our assessment. How do you check muscle power for bicep? You ask patient, okay, bend your elbow, right? And if the patient is not able to bend, what is your treatment? Come on, bend your elbow, bend your elbow. And if patient says, sir, I'm not able to stand straight, what is your treatment? Stand straight. If patient says, I cannot bend my knee, what is your treatment? Come on, bend your knee, bend your knee. So your assessment is your treatment in physiotherapy, right? And in manual therapy, your treatment is your assessment. So you give a glide to check if the patient is responding or not. And if the patient is responding with the glide, that means opposite of that was the positional fault. And if patient is not responding with your glide, you change glide a little bit here and there because of the various anatomical variations. We both are looking different. Okay, though I'm much younger than you, but still we are looking different. Okay. No, just kidding. Okay, so we both look different because of the anatomical variations. Okay, because of the anatomical variations. Your nose shape is different. My nose shape is different. Height of the vertebral body is different. Orientation of the facet joint is different. So we cannot push in the same direction. So if we are not getting the result, change the angle, direction, pressure, force, and check if that is working or not. Still not working? Okay. Thank you very much. Don't do it. Say send back the patient. Say you need rest. Take the second opinion. Check the red flags. Thank you.
Sir, so participants, those who are with us today, so they can again join our practical session on next Sunday. Yes, sure, sir.
Yes, please. So please. They have to sign up at our website, and we'll make that chapter available for free, and they can watch that chapter for free, and they will learn it. Next Sunday, they can learn those provocative tests and the special active range of motion, passive range of motion at sacroiliac joint, and the segmental examination of the sacroiliac joint. They can watch it next Sunday.
Sir, yes, sir. Also, sir, you have started the that is a COMT workshop through the online, sir.
Yes, we have started, and it's a very unique. Thank you for asking, and thanks. We'll be able to tell the people this is a very unique concept we have come out. Not online concept is unique. Online, everyone have been doing, but in our online, what we are going to do, in addition to the video clips which they will see, after seeing that video clips, they will be answering certain question online, multiple choice question, and only if they learn properly, then only they will be able to answer correctly. And after doing that, they will be doing their own recording and sending back to us. And I will check those video recordings personally and then comment on those video recordings and tell them these are the mistakes. So though it is online, but it will be same like hands-on. So without getting in touch with each other, we are still doing the hands-on. So they will not only watching me, I will be watching them also, because they will send the video. Okay. And there are so many other benefits they will be getting, and then they will get the certificate also, which is again, we got tie-up with the university also. So the certificate will be issued by the Capri Institute and the university jointly. It's a Charusat University in Gujarat. So they will be getting the certificate issued by the university and the Capri Institute.
Thank you, sir. Sir, it's a 3 months duration, sir?
Yes, it is 3 months duration, and in that we have more than 200 techniques covered, and it is 165 chapters included in that, and uh, more than 42 hours of video quality content. It's a beautiful one, and we have recorded the manual therapy techniques from the best angle, uh, which they will appreciate. There are few samples we have made available, and if they see those samples, they will understand what we are talking about. And then we have put the arrows for the dynamic stabilization and the static stabilization for the mobilization. And even if a below average person see those videos, they will learn manual therapy.
Yes, sir. I think that will be great one. So participants, already we have shared our feedback link, so you can complete your feedback link feedback form, and then directly you can access the certificate. And already sir had completed his nomination about the design and everything from the morning. So thank you, sir. And from the morning, where you have given me time, and the very first morning, I think.
It's
So
my pleasure, dear. It's really a
thank you.
pleasure. And I must say, thanks to you, thanks to Physio News 24, thanks to Dr. Shamim, and most importantly, all the participants for listening to me patiently. And I hope they all got benefited, and we shall communicate and talk to them in the future on your channel again, and on some other topic, on some other discussion. And again, just one small message: just don't follow books blindly. Try it yourself. Okay, think critically, challenge everyone, and try to see the rational behind physics behind each and everything. Physical therapist means physics. Remember, medicine can change physiology, not the physics. And we physical therapists, we change the physics, the biomechanics of the body. So we do what medicine cannot do. Feel proud being physiotherapist. Thank you very much.
Thank you, sir. Thank you very much. Thank you, sir, for your time, sir. So we can conclude today, sir. Thank you, everybody. Thank you, all participants, and special thanks to my mentors in this manual therapy, Dr. Deepak Kumar, sir. And maybe in near future we can join again. And all participants, just go to the live chat room, and there we have shared maybe more than one time. That's the feedback link. And after completing the feedback link, maybe during this time, it is very jam-packed time. Like everybody, they are trying to fill up that feedback link. That's why sometimes they didn't get that link or access that link. So I think if any problem, then you can try in the lonely time, like in the morning or the very next day. So don't worry, because already we have given the certificate on the Google. So any time, any suitable time, you can click on that link and just keep that form link, feedback link on your any other secure place. So if it is not opening now, so maybe in a few later, like not today or tomorrow morning, you can easily access that link and get the certificate. So don't worry. And also another thing, so we have to clear that through your registration, we have got some data from you. So that data I will share with our today's facilitator, Dr. Deepak Kumar Capri, sir. And then he will access your data, and then he will again invite you for his next webinar on Sunday. So don't worry. So you will be available. Yeah, that's you can maybe start from our SARS organization. They can send you email or any type of information through your email. So thanks for having a patient. Already is 1 hour and more than 25 minutes. So maybe we can see you later. See you next time with next topics. Like next Sunday, we'll get one of the eminent teacher. He is a MBBS doctor from India and is a very oldest person in acupuncture. So our next Sunday, we can cover a lecture on acupuncture. And then after that, Saturday, we will get another renowned physio, Dr. Shubhanjan Das, and he will come with dry needle. So next 2 weeks we will cover. Last next Sunday we'll cover the acupuncture, and then next after that Sunday we'll cover dry needle. So thank you everybody, and thank you for today. Thank you.